colorectal and pancreatic cancer. It was a pretty big topic, and she'll probably tell you how she pared it down a little bit.
So I was told to talk about GI cancers, which in the BCOP review covers colorectal, pancreatic, gastric, esophageal, and liver, which I could not fit into this 60-minute talk. I got the most questions from colorectal and pancreatic, so I figured that those would probably be two of the better ones to go through, but there's definitely a lot more information in like the BCOP review materials, so absolutely go back to them for Oh, there we go. So in terms of the objectives for today, I wanted to discuss treatment modalities for both colorectal cancer and pancreatic cancer by stage of disease. I know that I got a lot of questions where they gave you, this is the stage of this patient, which is the appropriate therapy, or is adjuvant therapy appropriate, etc. when I was taking BCOP. And then I did do a few patient cases to help apply those principles. So first, I'd like to start with colorectal cancer, and we're going to jump right into a patient case. So Jed Junum comes into your primary care clinic to refill his blood pressure medication. You realize his birthday just passed, and now he's 50 years old. You ask him if he's scheduled any screening for colorectal cancer yet, and he tells you that he's not aware of any screening or what is needed. So first, my first question that I'm going to pose to you, and I do want this to be interactive, so please respond, but what screening tests for colorectal cancer are available for JJ? Yes?
Occult blood and colonoscopy.
What was the first one?
Occult blood.
Occult blood, yep.
And colonoscopy.
And a colonoscopy. Those are two options. Does anybody know of any others?
Well, the CEA, but...
The flex sigmoid, yep. Sigmoidoscopy, I believe.
A flexig?
Yep, the flexig is an option.
Isn't there a soft recommendation for imaging? Isn't there like a
CT colonoscopy,
yeah,
perhaps? Also another option, and we will go through all of these, so let's move in. All right, so colon and rectal cancer, it's the third leading cause of cancer death in men and women. The 5-year survival rate is approximately 64%. There's a number of risk factors for colorectal cancer, and there's another number of genetic predispositions that could put patients at risk. So the first one being familial adenomatosis polyposis, or FAP. And so for that, that's about up to 1% of all colorectal cancers, and it's caused by mutations in a few of the different genes, including KRAS. And 50% of patients with this will actually have an adenoma or precancerous polyp by age 15, and 95% are going to develop some sort of precancerous polyp before age 35. If those don't get treated, then 100% of these patients will have colorectal cancer diagnosed by age 40. The next one down, hereditary non-polyposis colorectal cancer. That typical onset for that is ages 40 to 44, and that's about 5% of all colorectal cancers. There are two types, so type 1 would be only colonic involvement, and type 2 would be anything outside of the colon, so those would be your patients with endometrial involvement or stomach, etc. The Turcotte syndrome, it's a gene mutation that's going to affect 1 to 3% of the population, and in addition to being associated with colorectal cancer, it's also associated with glioblastoma and medulloblastoma. Inflammatory bowel disease, both ulcerative colitis and Crohn's disease, increases your risk. So ulcerative colitis will increase your risk by a 5-fold increase, whereas Crohn's actually increases your risk of colorectal cancer by a 10-fold increase. Tobacco, particularly more than a 35 pack year, is going to really increase your risk, as well as a sedentary lifestyle or obesity. And that's usually, they considered about like a 2-fold increase. And then in terms of diet, so patients who have a high-fat, low-fiber diet with a lot of red meat consumption and a lot of alcohol intake will have an increased risk of colorectal cancer. And then in terms of family history, even outside of the genetic predispositions, if you have two first-degree relatives or one first-degree relative that had colon cancer under age 50, you have a 3 times greater risk. looking at the risk factors, a lot of those are things that we can modify, and it allows for a lot of prevention strategies for colorectal cancer. So this chart was taken straight out of the BCOP materials. So things like fiber supplementation, if you have a low fiber diet and that increases your risk, then adding fiber to your diet should hopefully decrease your risk. And same with dietary fat reduction. In terms of the cyclooxygenase inhibition, COX-2 expression is enhanced in 90% of colorectal cancers. And so the benefit of NSAIDs, or the COX-2 inhibitors, and by that I mean at least 2 or more tablets taken per week, it's been shown to help prevent colorectal cancers. It is strongly dose dependent, and it is specifically the prevention of, and it does not help in the treatment of. But this actually does even help patients who have the genetic predisposition. So when talking about who to screen, and this brings up a lot of the tests that we had previously mentioned. So just going down, the fecal occult blood test. So that has been shown to decrease mortality secondary to early detection in asymptomatic patients. It is pretty inexpensive, and it is easy to use, though the results do need to be followed up on with like a colonoscopy, for example. More than 50% of cancers do still go undetected, though, because if it's not bleeding at the time of this test, then you would have no reason to detect it. The fecal immunochemical test actually uses antibodies to detect hemoglobin in your stool, but again, you have to follow up with the results follow up on results with a colonoscopy. Stool DNA tests screen for the presence of red blood cells and DNA mutations in your stool that might indicate cancer. The Flex Sig, it's really only useful at looking at the lower 35 to 60% of the colon, which means that it can miss about 50% of lesions. But it can be used to not just look at the polyps, but also biopsy and excise them at that same time. We all know about colonoscopy, which is our gold standard, so it does give you the full view of the colon, as well as allows for biopsy and excision during the procedure. It is pretty highly sensitive. It still may miss smaller polyps, but overall it's a better rate than some of the other options. But of course, it's kind of unpleasant for patients to take the bowel prep and everything. The CT colonoscopy also doesn't view the entire colon, but you still need the full bowel prep. It is an expensive test, and being that it's just imaging versus the actual colonoscopy, it's less able to biopsy the lesions as you see them. And in terms of the barium enema, it actually does have a full view of the colon, and it is one of the least expensive options, but it does have a high false negative and false positive rate, and it's pretty unpleasant to have an enema every 5 years. So just to kind of give you in terms of like number needed to treat, in order to detect one colorectal cancer, 154 patients would need to have a colonoscopy, 166 patients would need to have a stool DNA test, or 208 patients would need to have the fecal immunochemical test. So just to sort of give you an idea of the rates for each of them. So back to our patient. He's now 50 years old and should undergo colorectal cancer screening. He does have a number of options, but like we said, colonoscopy is really what our gold standard is, and you can kind of see that based on the fact that it's once every 10 years versus annually or every 5 years. And so he says, all right, sure, I'll take your advice. Let's schedule some follow-up, and he begrudgingly has his first colonoscopy. Several polyps were identified and removed during the procedure, and a large mass was found in the transverse colon. A biopsy was performed and showed adenocarcinoma, and he's told that further workup does need to be done. So he undergoes a CT of the chest, abdomen, and pelvis, which is negative for any sort of metastatic disease. So at this point, what therapy should he receive? Surgery. Sounds good. All right. So when we look at the prognosis, there's different risk factors, as with all cancers, that are favorable versus unfavorable prognosis. And one of the most obvious would be early versus late stage disease. But you can see here a few of the other based on lesion size, etc. In terms of the treatment modalities, surgery can be used for cure or for palliation and management of symptoms. Colorectal cancer, a partial colectomy is typically done with complete resection of the tumor in nearby lymph nodes. I believe you have to get 12 lymph nodes before you can say that you don't have any metastatic disease and it has not spread to the lymph nodes. For rectal cancer, typically it's a transanal incision if there's a small superficial tumor versus if it's a larger tumor or in the lower third of the rectum, it would be a transabdominal incision. And so that often would require a permanent colostomy. When we talk about radiation, it's a pretty minimal role in colon cancer, only really T4 disease, which means that it's disease that's grown outside of the bowel and invading nearby organs that you would really consider using radiation on. Versus rectal cancer, you would use radiation in a lot more stages of cancer, everywhere from neoadjuvant to adjuvant therapy in terms of trying to treat curable disease. For chemotherapy, we can use it both again in the adjuvant setting as well as in the palliative setting. And when we're doing adjuvant chemo, it usually begins 4 to 8 weeks after the surgery, and it continue for about 6 months. Usually this is primarily 5-FU-based regimens, which we'll talk about in a little bit. So as I said, when I was taking BCOP, I had a lot of questions that were like, this is the stage of your patient, what therapy is appropriate. So I made this chart to sort of break it down by stage and discuss, to help just have a reference in terms of basically what that stage means, what the goal of therapy is, and what the primary treatment modality should be. And as you can see, and we'll get into it a little bit more, when you talk about stage 2 or stage 3 disease, you would consider maybe the adjuvant chemo following surgery versus just surgery alone in stage 1 disease. And when you get to metastatic disease, you still can talk about surgery in a select number of patients, and we'll talk about who, but also really you would start considering systemic chemotherapy options. So Jed does not have metastatic disease, and it's appropriate for him to undergo surgical resection. After his wounds healed, he presents to the GI oncology clinic to discuss whether he should undergo chemo. His tumor is determined to be a stage 3 tumor, and he has a pretty good performance status. So at this point, what postoperative therapy would you recommend? Chemo. All right.
Adjuvant 5-FU or CAPE-based.
Adjuvant 5-FU or CAPE-based.
Not irinotecan-based.
Not irinotecan-based. All right. Good work. So, looking at the adjuvant therapies for, based on the NCCN recommendations for adjuvant treatment, a bunch of the regimens are listed on there. So you would consider, like Jason had said, adjuvant chemo with a 5-FU-based regimen. And when you look at like the Roswell Park versus the Mayo Clinic regimen, which I believe I have on a later slide, on the next slide, the efficacy really doesn't change too much, and it's more the toxicities that you might pick based off of. You would consider the addition of oxaliplatin for adjuvant therapy in stage 3 disease. It's not necessarily recommended in stage 2 disease until you have those patients with the high-risk features. And the reason for that is that based on the Mosaic trial, at 6-year follow-up, there was no difference in disease-free survival or overall survival for good or intermediate risk stage 2 patients, but they did show in the high-risk patients that the disease-free survival was 72% versus 68% and also for stage 3 patients, and it did have a 20% risk reduction of recurrence for these patients. Irinotecan and the targeted agents right now don't have any place in adjuvant therapy. And then that little statement on the bottom that says patients with stage 2 disease should be tested for DMMR. What that is it's the defective DNA mismatch repair. And so it's primarily tumors that end up on the right side of the colon and have poor differentiation. They're typically mucinous histology. And these patients don't benefit from 5-FU adjuvant therapy. There's no benefit in disease-free survival for them. However, without 5-FU therapy, it actually is usually considered a good prognostic indicator, and they would have disease-free survival just with other therapies. And this is in terms of just looking at some of the 5FU-based therapies. So if you look at, like I mentioned, Roswell Park and the Mayo Clinic regimens, so they're 5FU-based therapies, just 5FU leucovorin with different schedules. And when you use therapies like that, the efficacy doesn't really differ between one to the other in the adjuvant setting, and it really depends on the toxicities. And what I mean by that is when you're giving 5FU, 5-fluorouracil, the adverse drug reactions are different based on the schedule. So when you think of infusional 5FU or capecitabine, which is essentially, it's a prodrug and it essentially acts like infusional 5FU, the dose-limiting toxicities are going to be different than when you think of bolus 5FU. So in your infusional, you have a prolonged exposure, so you see more of the hand-foot syndrome for these patients. They also still will get mucositis and diarrhea, though you'll see a lot more of the skin changes like you would with the hand-foot syndrome, so the skin discoloration, the nail changes, and some photosensitivity. When you're giving bolus 5FU, you primarily will see the myelosuppression, though these patients do still get some of the mucositis and diarrhea. And so when you have a patient who's receiving these regimens, or a patient who's receiving a regimen with both options, you can sort of decide how to modify their therapy based on what side effects they're presenting with. So back to our patient. So with his stage 3 disease, it is appropriate for him to undergo adjuvant chemotherapy for at least 6 months. And since he is stage 3, we would probably add the oxaliplatin piece and use either FOLFOX or CAPOX, which are the NCCN preferred regimens. How would it have changed if we had stage 2 disease for him with low risk features or moderate risk features? Anybody on the phone want to answer? Guess I'll read it out.
Crickets. Crickets.
Somebody guess.
It's like just a 5FU.
Yeah.
kind
You
of
would
thing.
use just like a 5FU based
Or
without.
just plain capecitabine.
Right. 5FU or capecitabine based without the oxaliplatin addition. So again, I just put it back on that slide again for you. So with no high risk features, you don't have the addition of the oxaliplatin. The higher risk features, you would treat them more like the stage 3 and have the oxaliplatin in there. So after this initial treatment, he presents to the GI oncology clinic 11 years later for a routine follow-up. He's missed a few appointments and a few scans, but he, had a lot of other things to do and couldn't make those appointments. So today he undergoes a CT of the chest, abdomen, and pelvis, and it shows a recurrent mass with a solitary liver metastasis. He's referred for a surgical consultation, and it's determined that liver lesion is actually resectable. So what would his treatment options be at this point? Metastastectomy? Yeah. Resection of the mat.
Yeah.
That could be an option. So for patients who have just a single solitary liver met or a single solitary lung met, you actually can still try and treat for cure by the resection of that met, as well as the treatment of the primary tumor in the colon. So you still would use, you still can do like a surgical resection of that primary tumor and use an adjuvant chemotherapy regimen following. You can try to use neoadjuvant chemotherapy prior to the surgery to help shrink the tumors, and especially to help to shrink that met to make that a little bit more easily resectable. And once it is resected, they should receive at least 6 months of adjuvant chemo with the regimens that we would consider for the advanced diseases. So at this point, you could consider something like a FOLFIRI or the targeted agents, even though it's post-surgery. So it's not necessarily, it's more of your advanced disease. I really like this chart that was in BCOP because it really goes, I know it's a little overwhelming up here, but it really helped me study because it goes through, if I use this for first line, what can I use afterwards? And I'm going to talk about a lot of things on this slide, so we'll be on here for a while so you can take your time studying it. So FOLFOX and FOLFIRI tend to be the two that we really think of, the two regimens that we really think of for colon cancer or colorectal cancer. And they both were initially trialed just against 5FU and leucovorin, and both were shown to have a higher progression-free survival and a higher overall survival, which we know combination chemotherapy tends to have better response rates in these patients, so that makes sense. But those are the trials that helped get them the first-line approved options. When they were actually compared against each other in sequence, so there was a trial that looked at giving FOLFOX and then FOLFIRI, as well as a trial that looked at giving in the same trial then other patients got FOLFIRI first and then FOLFOX. They both actually held up both as first-line agents as well as second-line agents, with overall survival of 21.5 months versus 20.6 months, so not statistically significant difference at all. The real primary difference with these regimens and why you might pick one over the other is just the toxicity profile. So thinking of the oxaliplatin, you have a lot more of the neurotoxicity, the peripheral neuropathies, the cold intolerance, versus irinotecan, obviously you have the diarrhea component. K-FOX actually was shown to be non-inferior to FOLFOX, so you can substitute the capecitabine in for the 5-FU or vice versa. Again, with the primary difference being the difference in toxicity profile. So with the 5-FU, the FOLFOX, you have the 5-FU bolus and the infusion, versus K-FOX, which just had the infusional side effects. When we talk about the addition of something like bevacizumab, Bev plus 5-FU did improve response rates in patients as well as prolonged survival. When it was given with FOLFOX, it showed an increase in the progression-free survival as well as a non-significant increase in overall survival. And when given with FOLFIRI, it increased the response rates as well as prolonged survival for those patients. And even in the second-line setting, it's been shown to increase the progression-free survival as well as the overall survival. So this is a therapy that we definitely would consider adding on, especially if we have someone with a really good performance status who doesn't have any sort of coagulopathy issues or doesn't have any sort of blood pressure problems, who would not necessarily have problems with the toxicity profile of bevacizumab. The drugs like the panitumumab and cetuximab that we would add on is going to be in your patients who are the KRAS wild type. So you can when added to the first line, it increased the progression-free survival, though there was a non-statistically significant increase in overall survival. In some studies, the overall survival is actually not even reported. So it's, I would think typically I've seen Bev added first, and then if you have somebody wild type, you might use the panitumumab or cetuximab after. When we talk about the difference between panitumumab and cetuximab, they do have the same mechanism of action, but the toxicity profile is a little bit different. So the cetuximab, you do see a lot more of the infusion reactions, versus the panitumumab, patients tend to have more of the skin toxicity. You do see the skin toxicity with both, but it seems to be a little bit worse with the panitumumab. And at this institution, we're in the process of working to switch from cetuximab to panitumumab, so this is going to be something that we might have to do a little bit more teaching on, as well as something we're going to have to monitor patients a little bit differently and maybe treat a little bit more aggressively if they do present with these rashes and these skin toxicities. If you have someone who doesn't have a great performance status and who can't necessarily tolerate some of the more intense therapies, there is still options for them, more with the single agent options, or 5-FU plus or minus Bev, or capecitabine plus or minus Bev. And then if, for example, the performance status is primarily due to the size of their tumor and the chemotherapy is able to shrink it and their symptoms improve and the performance status improves, you can consider one of the other therapies. When it says as above, it means the previous chart, since I did also take this from the BCOP materials. Or you can also always consider best supportive care on these patients. This is another chart that's probably a little bit confusing and harder to read on this slide, but there's a lot of detail for this in the actual BCOP chapter, so definitely would recommend looking at that. But for rectal cancer, there's a few differences. When you look at the treatment modalities and look at where we would add in radiation, for example. The rates of local recurrence are really high in rectal cancer. So stage 1 disease, it's like 5 to 10%. When you see stage 2 disease, you'd see 15 to 30% of local recurrence. And stage 3 disease, over 50% of those patients are going to have a local recurrence. So you definitely use a lot more aggressive adjuvant and neoadjuvant treatments for these patients. You also, when you're doing the treatments, you'll use oxaliplatin a lot earlier. So even in like the clinical stage 1 disease, for adjuvant therapy, you would consider something like FOLFOX or K-FOX for these patients as preferred regimens. Another big difference, as I mentioned, is the use of the radiation. That's a lot more frequent and a lot earlier. So for these patients, when they are even in stage 1 and getting adjuvant treatment, you can consider chemo and radiation as the adjuvant therapy. Before I move on to pancreatic cancer, did anybody have any remaining questions about anything for colon or rectal cancer or something else you wanted to talk about with our patient case? All right, so jumping into pancreatic cancer. Irene Otikan is a 67-year-old woman who presents to her local primary care physician complaining of pain that radiates down her back. Upon further questioning, you find out that she has lost 20 pounds in the last 3 months without trying and does not have much of an appetite. Otherwise, she's a relatively healthy individual with past medical history of type 2 diabetes, but it's really well controlled with metformin. She does have a 20-pack-year smoking history, but she did quit 10 years ago. So, based on this information, what are IO's risk factors for developing pancreatic cancer? And what symptoms is she experiencing? You could give me either of those answers.
Pain, smoking,
Loss,
weight loss.
So pain and weight loss would be two of the symptoms. Smoking would be a risk factor.
Mm-hmm. And her age, sorta. No.
Her age is sorta a risk factor. Jason, did you say something different? I didn't hear.
Appetite? Lack of appetite?
The early satiety.
Ooh, I don't know about diabetes at all. I don't know that.
What about diabetes?
I don't know.
All right.
I think I'm gonna learn something.
We'll talk about diabetes. I hope you're learning something.
I love when I learn something.
For pancreatic cancer, it's one of the lesser common cancers. It's not something that you're going to see as much of like colon or breast cancer, but it is the fourth cause of cancer deaths, the fourth highest cancer killer, essentially. So while a lot of patients don't necessarily get pancreatic cancer, unfortunately, a lot of patients do die of it. The average age of diagnosis is 65. So most patients are going to get diagnosed between like the 65 to 70 range, greater than 70% of patients. It can arise from the endocrine or the exocrine parenchyma of the pancreas. Most of them end up being exocrine, and 90% of these end up being ductal adenocarcinomas. KRAS is mutated in 85% of these cancers. So if you think about like the agents we discussed with the KRAS wild type, those are not going to be options for patients with pancreatic cancer. In 95% of cancers, I thought this was interesting, the P16 tumor suppressor gene is inactivated. So it's definitely one of the genetic features that we would associate with pancreatic cancer. When you talk about risk factors, cigarette smoking is a 2 to 3-fold increase, and it's associated with 30% of pancreatic cancer cases. The diet, again, is similar to colon cancer, where it's the high fat and the processed meats that can cause a higher risk in these patients, as well as the obesity. Diabetes does come up as a risk factor for pancreatic cancer. So that could have been one of her risks when we were talking about our case. Patients who have chronic pancreatitis, often when it's caused by excessive alcohol intake, that will increase your risk of pancreatic cancer, as well as occupational exposures. And when we talk about the familial component, 5 to 10% of cases are familial of pancreatic cancers, and typically these are the cancers that present at an earlier onset, and smoking plays a really significant part in these. So if it's a family of smokers, they have a higher risk of having that familial aspect. At this point, there's not really any good screening for pancreatic cancer. The tumor marker that we usually associate with it, the CA19-9, it's not often elevated in early disease, so by time that would be elevated, if we use that as a screening tool, it would usually be too late. So talking about our patient, the smoking history of the 20-pack-year history definitely increased her risk, as well as the diabetes may have increased her risk. So her age was over that average age of diagnosis, so that's kind of a soft call risk factor, but it could have been, she likely might not have been diagnosed if she was younger and healthier. In terms of symptoms, when you have that back pain, especially pain that radiates from the front to the back, that typically is associated with pancreatic cancer. The 20-pound weight loss definitely was, as well as the early satiety. And in some cases, diabetes is actually also a presenting factor for pancreatic cancer. So it's funny that you had said you didn't know which one it was, Sarah, because it really could have been both. Other symptoms that I didn't necessarily list on here that could have happened, jaundice. Some patients might present just based on the location of their tumor with jaundice. Pain is actually the presenting symptom in 80 to 85% of patients with locally advanced or metastatic disease. And like I said, it's typically that pain in either the back or the upper abdomen that radiates. Sometimes it'll radiate up to the shoulder. The weight loss is a very common one, as well as clots. A lot of these patients will have a clot that is then later associated to this occult pancreatic cancer that was not noticed at that time. So unfortunately, it's a lot of really nonspecific symptoms until you have advanced disease. So at the time of diagnosis, 85% of tumors have already extended beyond the pancreas. So that is one of the reasons that it is such a hard cancer to treat, and it's also it's hard to catch it early enough so that we can do surgery and remove it and hopefully cure these patients. So Irene undergoes workup for her symptoms, including a CT of the chest, abdomen, and pelvis. The scan reveals a mass in the head of the pancreas without any evidence of any sort of vessel involvement or any metastases. The biopsy does show it's an adenocarcinoma and likely pancreatic in origin. So is she a candidate for a surgical resection of the pancreatic mass? I'm getting a lot of nodding, so yes. When we talk about pancreatic cancer, we do stage it based on the standard TNM staging system. However, to really get a good view of this, you would need like a surgical specimen, or would be able to go in and have to look at the lymph nodes, which is not an option for a lot of pancreatic patients. So we kind of break it down into what we call clinical staging. So patients who have resectable disease, who have borderline resectable disease, who have locally advanced unresectable disease, or who have metastatic disease. Unfortunately, like I've mentioned, it has an extremely poor prognosis with less than 20% of a 1-year survival and only 3% 5-year survival for most of these patients.
Can you say that again? Less than 20?
Less than 20% 1-year survival and 3% 5-year survival. And that's including all of them, so that's including the metastatic and stuff. When you talk...
It's not much better, at least one happened over the years. It was like this 20 years ago.
Yeah.
It's awful.
For patients who have like a local non-metastatic disease, typically their prognosis, you think about like 8 to 13 months. And when you talk about metastatic disease, most patients are given like 3 to 6 months. So unfortunately, not a ton of advances yet. Surgery is a treatment modality if you can catch it early enough. The most common surgery that we would do would be a Whipple procedure if it's in the head of a pancreas, and so that's a pancreatic duodenectomy. So it takes out a whole bunch, which we will look at in a picture. If a patient has a tumor in the body or the tail of the pancreas, you can do a distal pancreatectomy. But unfortunately, a lot of those patients, it's already sped beyond. When used post-op, radiation alone doesn't improve overall survival. However, when it's combined with FFU, you do have statistically significantly longer overall survival of 20.9 months versus 11 months in terms of adjuvant therapy. And that's versus patients who just underwent observation after their surgery. Neoadjuvant radiation has been shown to improve the resectability rates, but that hasn't really relayed into a benefit in overall survival, unfortunately. So we're able to take it out more, but it doesn't necessarily extend their life in the long run, and likely it's a fast recurrence. We do use some palliative radiation and palliative chemotherapy to help to control symptoms, particularly pain. You can use chemotherapy in the adjuvant setting with either 5FU or gem-based regimens, typically single agent or with radiation. But the response rates are still pretty low, and it is not curative. Combination chemotherapy does improve response rates with minimal improvement in median overall survival, but really the summary of this is that our treatment options aren't great, and all patients should be considered for a clinical trial first. That would be your preferred treatment option. I did go back and do treatment by stage, but rather than doing the stage 1, 2, 3, 4, I did it based off of resectable, borderline resectable, the locally advanced unresectable, and metastatic, which is how I got the questions in the BCOP. The goals of therapy, it's not a lot of curative intent, mostly just because you don't catch it early enough for these patients, but it is really trying to prevent progression and to keeping stable disease for these patients, as well as a lot of palliation of symptoms. Adjuvant and neoadjuvant therapy is indicated earlier in these patients due to the high local and distant recurrence rates. There is a higher use of radiation than like colon cancer, which we just discussed. Post-op chemotherapy plus or minus radiation is your standard for any surgical patient. Both are better than observation separately. Together, they're better response rates. The adjuvant chemo only has a 25% risk reduction for death, though, so even I'm telling you this is better than observation, but it is only 25% risk reduction. The clinical trial is still really the preferred option. There is limited evidence for specific neoadjuvant regimens, so even though I have it on there and I'm telling you it could improve your resectability, there's not really great recommendations on what regimen is going to be the best or what will work. In most of those patients who are getting neoadjuvant chemo, it should be on clinical trial. And for patients who have an unresectable tumor, there have been trials looking at chemo alone versus chemoradiation, and up to this point they have some similar median survival. So historically it's been chemoradiation has been your standard, but some institutions will consider chemotherapy alone based on this data. Especially in terms of when you think of the toxicities, when you use them both together, you do have a little bit more toxicity versus just one modality versus the other. So there is specific criteria for resectability, and only about 15 to 20% of patients are going to be eligible for a complete resection. And it's because they need to fit this criteria where obviously no distant metastases, that one makes sense, but you have to have no radiographic evidence of any sort of vessel involvement or anything that's pushing on the vessels. The closer you get to the vessels, the harder it's going to be to resect that. It's going to be hard to get negative margins around your tumor, etc. And so I have a whole bunch of words that are highlighted. It was very overwhelming to me until I pulled up a picture. So all of the highlighted words are the ones that I have in red, but basically it just illustrates what they were mentioning is all of the vessels that surround your pancreas. And in order to be resectable, it can't be really anywhere near any of them, which is why it's so hard for these patients to actually meet resection criteria. So our patient, she had no evidence of metastatic disease, which was great. She had no encasement or occlusion. She had no direct involvement of any of those veins that were in that picture. So she actually was able to undergo a Whipple procedure for her pancreatic cancer. She received some adjuvant chemotherapy with gemcitabine for 4 cycles, and it was followed by some extra chemoradiation with capecitabine. She tolerated this therapy well and was actually able to get back to her normal activities. She's now following up 18 months out from her initial diagnosis, and she's here for the results of her surveillance scans. Her CA19-9, which I had mentioned is that tumor marker that we do use sometimes, is above 1,000, and there's a new liver met noted. Her performance status is still really good, and she's otherwise fairly healthy. What treatment options does she have for the treatment of this metastatic pancreatic cancer?
FOLFIRINOX, which would be not one that I would choose.
Yeah, because of her performance status, she's still
Yeah, she
undergoing
would
that.
still do it.
Well, I just
With her performance status, she probably could tolerate it, yeah.
without
Gemabraxane would be really your other option. So
with gemabraxane, the response rate is higher, but people still die just as quick. I mean, we're not really increasing survival.
Yeah.
More people are living, but not much longer.
Yeah, essentially. Longer than previous?
Oh, no, see, I was surprised that Erlotinib's still in there.
I was too.
Do we use it at all here anymore?
We weren't going to use it at all when it was FDA approved. Our doc said they would never use it for an 8-day survival advantage, but patients started demanding it.
Yep.
And then everybody got it for a while. Then it was FOLFIRINOX if you could tolerate it, and then finally when the Abraxane data came out, that's the switch, and that would be the standard.
Yep.
And that's the problem with some of our clinical trials and being able to enroll people is the comparator arm is gem, you get gem alone, and that's really not the standard.
Not your standard
when it opened
anymore.
up, if it's
Gemabraxane
gem plus something or placebo, you're just getting gem alone, and our docs are like, can't do it. Yeah.
Yeah, I guess it's a technical issue.
Well, it's tough.
It is,
really
yeah,
is.
it is sometimes an ethical
And it's
issue.
really hard to
Yeah.
redesign a trial in the middle.
Right.
Can't do that. Oops.
So I actually also thought it was really interesting for pancreatic cancer. When gemcitabine was approved for it, it was approved on this like clinical benefit, which they classified as an improvement in pain, an improvement in lean body mass, and the Karnofsky performance status. So they didn't look at progression-free survival, they didn't look at disease-free survival, they definitely didn't look at overall survival. And that was enough improvement in these patients' quality of life that it got approved.
All we used to have was 5 of these.
Right, and that was all we had.
When we were born, and that was it.
Yep.
I remember when gemcitabine was approved. It was pretty exciting.
I also thought it was interesting and something worth bringing up. So if you look under like the poor performance, the first option is the gemcitabine standard dose and infusion rate, which we likely would use a standard dose and infusion rate. But the next one down is this fixed dose rate. So what that was is the thought, because with gemcitabine we know if you extend the infusion you'll have a prolonged exposure to the drug. So we thought that maybe that could be more efficacious. So they gave the infusion as a 10 milligram per meter squared per minute. And this was in a phase 2 trial, I believe, and they thought that, well, maybe this works better. They looked at it in a phase 3 trial, and it didn't really play out. And when you do have the longer infusions of gemcitabine, you do increase the exposure, but that means you increase the toxicity. So a lot of these patients had really significant myelosuppression, especially your thrombocytopenia, and not a lot of patients would be able to tolerate it.
We did that phase 2 trial here with this bar.
Yeah. But it's still listed as a Category 2B option.
He did.
Yeah, it's still listed though as a Category 2B option because we don't have a lot of other options, unfortunately. When you look at Gem plus, it's been looked at Gem plus 5-HU, Gem plus cisplatin, Gem plus irinotecan, Gem plus oxaliplatin, Gem plus capecitabine. None of these have been better than Gem alone. So we keep trying to combine Gem with things, and it's not really playing out too much. Gemrolotinib was the first one that really showed some sort of advantage in 2007. Yeah, and it was a median survival of 5.9 months versus 6.2 months, and that was what got its approval. They did show a 1-year overall survival of 17 versus 23%, so a very minimal overall survival benefit. The side effects of the combination wasn't significantly worse, minus the ones that you would expect to see with the erlotinib. So especially like that rash, the acneiform rash that patients get. And so they noticed that when patients get this rash, it tended to show that the drug was working and that some patients responded better. So that was at least, because my dad actually was on gemrolotinib, and that was how they told him, like, just deal with the rash because it means the drug is working, which he hated it. I didn't blame him. He looked miserable. I wouldn't blame anybody for not wanting to do that, but it's thought to be associated with efficacy because it shows that the mechanism is at least working for the drug, but it's pretty miserable. FOLFIRINOX, where is it on there? Oh, it's the one listed right after clinical trial. So that's our Category 1 recommendation. And so in a phase 2-3 study, it was tested versus weekly gemcitabine in newly diagnosed metastatic pancreatic cancer patients. The quality of life was actually similar for the first 8 months, which I thought was pretty interesting, with the exception of the diarrhea and the FOLFIRINOX. And then at 6 months, actually, the gem-based arm had a decrease in the overall survival. And part of that probably was that they didn't, typically 6 months was about the time, the overall survival difference was 11 months versus 6 months. So a lot of those patients probably were having advanced disease and progressing on it. But I did think it was interesting that despite having 5-FU, oxaliplatin, and irinotecan in one regimen, the quality of life wasn't that different. And it does have that improvement in overall survival. So this is really the first time that we had patients living almost to a year, which is sad. Then Gem-Abraxane came out, actually, this was when I was a resident, and that was also versus Gem alone. And it was also in newly diagnosed metastatic pancreatic patients. And they did show a decrease in the tumor marker, the CA19-9 for these patients, as well as an overall survival benefit of 8.5 months versus 6.7 months. Patients did tend to respond better to the combination versus gemcitabine alone. So these are like the only two options where we've really shown any overall survival benefit since gemcitabine was approved, and I think that the original trial is like 1999 or something. So that's like, that's too long, really. And that's why it really is important to get these patients enrolled on clinical trials. We clearly need more data for this tumor type. We need something that works a little bit better. So because IO does have a good performance status and does have overall good health, both would be an option, both the gemcitabine nab-paclitaxel as well as the FOLFIRINOX. But like a few of us have already said, the FOLFIRINOX tends to have a lot more toxicity and is more poorly tolerated. So that's really going to be your young and healthy patients who want to try everything that they can, versus your gemabraxane, most people can tolerate pretty well. If she did have a poor performance status, you still can consider using the gemabraxane, the gem-nab-paclitaxel, or you can try gemcitabine single agent or gemcitabine or erlotinib. If she does progress following this first-line therapy, what options would be available for her?
Don't forget clinical trial.
Don't forget clinical trial.
Oh,
So there's no standard of care. That was a little bit of a trick question. It's been poorly studied mostly because patients typically don't get to the point where they have another regimen, and we don't really have a lot of other regimens to try. The clinical trial is always your preferred option, both first line and second line. If you've got a gemcitabine-based regimen, you could try to switch to a 5-FU-based regimen. If you got a 5-FU-based regimen, you could try to switch to a gemcitabine-based regimen, but realistically, there's not a whole lot of benefit from either. There was a study that tried looking at best supportive care alone versus 5-FU oxaliplatin plus the best supportive care, but it actually was even closed due to low recruitment because so many providers just accept best supportive care as a good option in this setting, so they weren't even able to recruit people into the trial. And on that depressing note, does anybody have any
coverage of some big topics.
Any questions on pancreatic or colorectal cancer, or I could try to go on some other GI malignancies if you wanted to ask. In terms of looking at stuff for BCOP and what test questions to do, I definitely got a lot of treatment by stage. I would know a little bit more about the drugs. Obviously, I didn't go through each and every drug, being that we're all pharmacists or pharmacy students. I feel like that might have been a little redundant, but things like the enzyme deficiency with 5-FU for the additional toxicity, the DPD deficiency, stuff like that. I would know. I did get questions. I didn't get that one, but I got like similar questions with other drugs. Dose-limiting toxicities of those drugs. I definitely got questions on the dose-limiting toxicity. A lot of it will be just giving you a patient case and saying, at this stage and this point in their cancer with these risk factors, what do you think is appropriate? And so a lot of it is based heavily off of the NCCN guidelines and recommendations. Does anybody have any other questions? All right.
Thank you for taking